Hello, everyone. It's good to see all the names pop up again today in our fourth installment of our Mobile Health Lunch and Learn series. I'm going to make a few announcements here as people come in. Once again, our series is hosted by the National Healthcare for the Homeless Council. My name is Cindy Manginelli, and I'm the Director of Community Engagement here at the Council. If you're not familiar with the Council, we are a national training and technical assistance program. And so we do education, advocacy, policy work, things like toolkits, publications, webinars like this, all kinds of work at the intersection of healthcare and homelessness. So if you've never gone to our website, I would encourage you to check it out. We have a lot of resources around mobile health, but tons of resources around all things healthcare and homelessness. And we are doing these series in conjunction with our good friends at the Mobile Healthcare Association, MHA. I would also encourage you to visit their website. They, specific to mobile health, have tons of information there, from everything from billing to different brands of different companies that produce units, all kinds of things at the MHA website. So I would encourage you to check that out as well. And today's session, all of this entire series has been funded by the Leon Lowenstein Foundation, a foundation with great interest and investment in mobile health. So we're very grateful to our friends at the Lowenstein Foundation. So in October, we did 2 sessions on safety and security. We did 2 sessions for mobile health. We did 2 sessions on billing for services for mobile health. And we've done these 4 lunch and learn sessions. We're going to put all of that together. I know some of you have been waiting for recordings. We're going to get all that together and hopefully have it in one spot. And I will hopefully be sending that out in the next week or 2. We are recording today's session. We have a lot of people who are watching this as a recording who are not able to be here in person, mostly because they are conducting mobile health services. So if you are one of the 60 or 70 or so people that are listening to this recording, I encourage you to reach out to me if you have questions that you would have asked if you were here, and I'm happy to research the answers to those. Once we have most people here, I will put my email in the chat, but we don't want you to, if you have a question or you want more information and you're listening to the recording, please feel free to email me. And I would just remind everyone as you ask questions that it will be recorded. We do want this to be interactive. We did limit somewhat the in-person participation because we wanted people to be able to ask questions and for it to be as interactive as possible. So feel free to put questions in the chat. Feel free to raise your electronic hand using the reaction button there at the bottom of your screen, the bottom of your Zoom screen. You can click the little arrow next to reactions and see how you can raise your hand. And we would be happy to answer questions even throughout the presentation. If you have questions, feel free to ask them. And then, like I said, you can also email me if there's additional information that you would like to have. So, like I said, in October, we did a session on safety and security, and Stephanie came and presented at that session and talked about Circle the City, and just amazing. We had so much positive feedback from that and so many people who wanted to learn more. And so as we thought about these 4 sessions, we've featured 4 individual mobile units. We knew we wanted to ask her to come back and tell us more because just such a positive response to the amazing things they're doing there. It's been interesting to me that as I've listened to the 4 sessions, I was really afraid that by the time we got to the 4th session, it would be like, well, we've heard all this, it's all the same. And it is really fascinating how every unit and every city is different. And that will be the same today. There are things that Stephanie is doing, that her program is doing, that we haven't talked about at all. So I think that's just fascinating, but also exciting. So I really appreciate Stephanie. I'm going to turn it over to her. And like I said, feel free to questions in the chat, raise your hand. Yeah, I'll turn it over to you. Thanks so much, Stephanie.
Thank you, Cindy. Thank you, everyone, for joining us today. My name is Stephanie Martinez. I am a member of the leadership team here at Circle the City, and I serve the organization as the Director of Community Outreach. I'm going to go ahead and share my screen with everyone. I have a PowerPoint to share with you all. Is that showing up for everyone? Perfect. Thank you, Cindy. So again, Circle the City has been around here in Maricopa County for over 10 years. We actually just celebrated our 10th year anniversary. A little bit about us. Our mission is to create and deliver innovative healthcare solutions that compassionately address the needs of men, women, and children facing homelessness. And our vision is a healthy community without homelessness. We were founded by Sister Adele O'Sullivan. Sister Adele entered the community of the Sisters of St. Joseph's of the Carondelet in 1968. She was a pharmacist and she earned her MD at the University of Arizona in 1984. Dr. O'Sullivan was working at a small family health center in El Mirage. She said she received a call one day that the county needed a doctor. Since my community trained me to become a physician to care for the poor, I took the job and my life has not been the same since. I can say that her life was never the same, and I can speak for a lot of us here that do the work that we do, that our lives have not been the same since, establishing an organization such as Circle the City. There was a steep learning curve to be able to address the needs of individuals experiencing homelessness medically, clinically, spiritually, right? There was a huge need in our community and continues to unfortunately increase as inflation continues. And there's a lot going on here in Arizona that has been impacting our patient population and specifically our seniors currently. Sister Adele learned not to take even the littlest things for granted when caring for this population. We indicate that in the slides, specifically when I talk about outreach, because oftentimes it's difficult. And for those of you that do mobile outreach or any sort of street medicine approach, oftentimes the worry is that you may not see that patient again, right? Or you may not see the big success stories of our patient getting housing, on outreach. It's difficult to see that as that one touch. So it's a reminder that I give my teams all the time is to not take the little wins for granted. It's really hold on to those wins, to those success stories, to continue to motivate us to do what we do. More about our history. The challenges that individuals experiencing homelessness face every day, as you all already know, is hygiene, wound care, knowing when their next meal is coming and where it's coming from and where they're going to obtain it. Medication management and storage, specifically for those individuals who have diabetes or need to store insulin. How do they do that and how do they manage their treatment? Vision and eye care is huge as well. These challenges are also led to further complications and the endless cycles of medical issues. People all over the valley started donating to Sister Adele as they started hearing about the work that she was doing. There is a term that we use here in Circle the City, even 10 years after we were founded by Sister Adele, is our shoebox fund. So those donations that Sister Adele would receive from just different individuals in the community, she would place in a shoebox, $10 here, $20 here, and she would use that to purchase a cane or to purchase eyeglasses or to purchase a car battery for a patient or things that they needed that wasn't costly. And then those donations started getting bigger and bigger, and they outgrew her shoebox. She was encouraged to start her 501c3, which she did, but to stay true and connected to the beginning and to stay connected to our mission, we still call the fund a shoebox fund. So when a patient enters our clinic and may need a walker or a cane or DME that insurance is not covering, or they're uninsurable, or their insurance lapsed, but we need this. When we make the request to our finance team, we still fill out the form that's called the shoebox fund, because that's where we started. And our hope is that we always continue to stay mission focused and mission driven. We serve more than 8,000 individuals experiencing homelessness across Maricopa County. Why do we need healthcare for individuals experiencing homelessness? Those experiencing homelessness face unique health barriers, lots of multi-factor illnesses, insurance and enrollment challenges. So those that are covered by state insurance, oftentimes if they don't go in to renew, if they don't receive that card in the mail with a reminder to renew because they don't have an address or they don't have a phone number where they're contacted, they face those challenges where their insurance lapse. And although they're eligible, they may not have had it for X amount of time until someone is able to assist them or provide them with an address where these letters can come to at a shelter, etc. The cost. So some of our patients who are on some sort of fixed income like Social Security or disability or whatnot may still have copays. And even if it's a $4, $5 copay for medication, that can itself be very devastating for them to afford. Transportation is huge. So transportation barrier is huge for any underserved community, but in particular for our patients. So transportation to their appointments and to follow-up appointments is very difficult. Then you have the judgment or from different clinicians. Oftentimes our patients do say that, I do not want to go in there because I haven't showered. So they feel like I just don't feel clean enough to walk in there. Circle the City has designed all of our outpatient clinics are designed just as an outpatient clinic that I hope the participants here also go to. Designed the same way with a waiting area, a lobby, exam rooms, but we also have a shower. Because again, we want to eliminate any barrier that we can. So if that's a barrier to them, they know they can request that shower. We provide it to them to be seen. Some say that they have not been able to find a place to shower in X amount of days. So we want to ensure that they feel comfortable, that we are that patient-centered medical home for them when they come to see us. There's also a low tolerance or understanding of mental illness and or addiction. And there's a lot of non-medical considerations. So where do they store their insulin? So somebody who is diabetic and a provider who does not typically treat an individual experiencing homelessness may not have the resources or the knowledge of, hey, have you considered this shelter who does have a refrigerator specifically for individuals experiencing homelessness? You can log in your medication here. You can use, that you could come to see them. They'll make sure that it's taken care of and logged. So if they're not well-versed in the resources out there for our patient population, then it's also discouraging for our patients. And which is why, again, we do what we do. We specialize in healthcare for individuals experiencing homelessness, and we take pride in staying connected with the resources, with the different community partners that also have that same focus in mind, right? And to serve our community. So our different care models here at Circle the City, our firstborn was our Respite Medical Center. Again, when Sister Adele Sullivan started her work here in Maricopa County, there was a huge gap. So patients or those facing homelessness that were recently being discharged from the hospital that needed additional care. They needed additional care for that wound that they were being seen for at the hospital that perhaps did not need that hospital stay any longer, or they just recently had a type of surgery. Their time at the hospital has ended. They did not need emergency services or hospital services, but where do they go? If they do not qualify for a SNF, where do they go and recuperate? And that's where our respite center was born. Sister Adele Sullivan saw that gap in care and wanted to ensure that we provided a safe place and time for our patients to heal here in Maricopa County. So we launched our first medical respite center in the heart of Midtown here in Central Phoenix. It's 50 beds, so 50 beds total. And recently, about 3 or 4 years ago, don't mark me on the dates, please, we launched our second medical respite center. So now we have 2 medical respite centers here in Phoenix, Arizona, 50 beds each for 100 beds total. Our second model of care is our outpatient clinic. So just like I mentioned, think of this as the same primary care clinic that you and I go to, but designed and tailored to meet our patients' needs. So we do have that shower. We do have food that's donated, or oftentimes we purchase to ensure that they have something to eat if they haven't ate, that they have water if they haven't had water, a place where they can store their belongings while they don't have to worry about it being stolen. They can focus solely on their treatment and care while they're with us. We launched our first outpatient clinic. It's our Parsons Family Health Center, again, here in the heart of Central Phoenix. And about 3 or 4 years ago, we launched our second clinic on the Human Services campus. So that's something that I should have mentioned. So the second respite center also sits on the Human Services campus, which is the largest shelter here in Arizona, in Maricopa County, I should say. So both our medical respite center and our downtown family clinic sit on the campus to provide those services to individuals around that area. And last but not least, but certainly my favorite segment, is our outreach programs. So Circle the City operates a variety of community-based initiatives aimed at bringing healthcare services to individuals experiencing homelessness. These programs include a 2-exam room mobile clinic, street and backpack medicine programs, bus pickups, and so much more. So now we're going to dive into more of the outreach segment and the outreach program. So this is just a model of the different segments that we offer within our outreach department. So we have our mobile medical units. We call them neighborhood partnerships. And I think that's a very important term that we have used, that we've seen a lot of success in. So for example, we have different regions. So we have North Valley, West Valley, Central Valley, et cetera. And we call them neighborhood partnerships. So North Valley neighborhood partnership, Central Valley neighborhood partnership, and the importance of that. And I feel that the true success that we've had in launching programs is that we connect with the community members. We connect with the neighborhood of where we are deploying these mobile units. We ensure that we try to help them understand the services that we do, the services that we provide, and try to eliminate some of the stigma that comes with seeing a mobile unit or seeing something that says healthcare for individuals experiencing homelessness or anything around that, because those, I'm not going to lie, as some of you may have experienced as well, those concerns do come up, right? Like, you're going to attract them here to the park, or they're now going to come and see you, so they're never going to leave from where they are. So we're there to say, we're partners in this. Let us partner together. They're here. This is their home. You are their neighbors. We're here to provide them medical care while simultaneously trying to connect them to social services. So in hopes that they aren't experiencing homelessness for that much longer. Can we solve this homeless issue by ourselves? Absolutely not. But we need neighborhood partnerships. We need community partnerships. And I say that because I think that's a huge success in the work that we do, is that we try to connect with these communities that we're launching in, and we create great, strong relationships with the community partners.
Quick question in the chat, and this may be relevant to the mobile outreach and the brick and mortar building, but you mentioned that you store the patient's belongings so that they can focus on their treatment and not have to worry about their belongings being stolen. The question was, how do you do that? What does that look like? Where do you do that? What's the process for that? And that may be applicable to mobile and to the brick and mortar, but
yeah. So for the mobile, we do not have the capacity to bring a storage with us, right? So for the mobile unit, we just either allow them to bring it with them if it's something that they can sit on their lap, or if it's something that's larger, we just say, hey, we're going to keep an eye out on this for you. You just come on into the mobile unit and somebody will keep an eye, and somebody from the staff will just ensure that nothing gets stolen while they're seeing the provider, just really ensuring that they're keeping an eye on it. As far as the outpatient clinics go, we do have storage where if they bring their bike, or they bring a cart, or they bring something before they check in to see the provider, we will put that in a safe place. It's kind of like those pods. I don't know what I think it is called a pod, like a pod with a lock, and our security will go and store their belongings in there. If at any time, let's just say that the patient was seeing the provider and vitals are not looking good, provider says, you know what, you need to go to the ED, they get upset about their belongings, we say, we will keep them here for you. We will keep them locked up for you until you're ready and healthy, and somebody will connect with you to ensure you have them. And that's just what we do to take that another worry off of their back and ensure that they feel comfortable with leaving their things with us. Thank you for that question. In regards to mental health, we just recently received a grant through the state of Arizona, and we launched our mental health street medicine program in June of 2022. And I'm going to go more into detail in regards to the mental health program and the services that they do. This is new to Circle the City. I am sure it's probably being done in other states and perhaps other programs here in Arizona, but this is new ground for us. So we are still learning and developing this program as we go. But one of the things that excites me the most is that our provider is willing to go and see patients where they are, where the need is. She'll provide psychiatric evaluations, and she's even allowed and able to prescribe on the spot. She's connected again with just different the medical community, and we're able to carry injectables. And if a patient, after establishing rapport and doing their psych evaluation, wants to get into treatment, we can do that as well. Then another one of our segments and newer segments that we have is our street medicine program.
Quick question about the mental health. So do you have, so I'm thinking of health centers that end up doing like crisis intervention, where even the law enforcement may call and say, we have someone who's in a mental health emergency, can you go out and meet them? Do you do things like that, or is it really more you've got scheduled appointments or a rotation you follow, and not so much, oh my goodness, we've got to get here now kind of?
Yeah, so we definitely, that's a great question, Cindy, because it's something that we've also had to really identify what's our identity, right? And what do we do? So we are not a crisis team. We do have, I wouldn't say scheduled appointments, because again, with street medicine and mobile outreach, we actually do not do any appointments. We just always carry our calendar and share, hey, come and see me, same place, same time here on Tuesday. So there's no appointments, but there is that routine, right, where patients can expect to, and that's huge for us. I think in one of the other lunch and learns, I have said, what's huge for us and the success is not being there once a month or the first Monday of the month. It's really that consistency week by week that registers in our patients being like, hey, it's Monday, where are they? And they will hold us accountable. If at any time I've had staff out sick or we're not able to deploy, I let the community partner know, but it's difficult to let patients know, right? Because you don't know who was expecting to see us, but they'll call the number and say, hey, where's the mobile unit? It's Monday, it's 9:15, you guys get here at 8:30. So the accountability is definitely there. But no, we're not a crisis intervention team. And one of the things that we do provide, or that this team does provide, is if our mobile outreach teams have a patient who another provider says, hey, this patient would really benefit from a psych evaluation. She seems to be willing to connect with you. Are you able to assist? If they're done with their site, or don't have any other patients that they're seeing, they will deploy out to go and see that patient and provide that psych eval. Especially if another provider is saying they're willing to talk to you, right? And that's the key, when the patient's willing to engage in services. Then we have our street medicine team. So also what we call backpack medicine, where it's not an actual mobile unit that they're in, but these teams are designed and tailored to go more into the parks or the places where our mobile units are not able to get to, those patients that perhaps are really not coming out to receive services or engage with social services in the community. So most of the time they're traveling through different parks. You'll see a picture right now in a little bit where they take a trail, where patients sometimes are in the trails, and they'll take a hike to come and see them. We just launched our first street medicine team for the East Valley here in Maricopa County a couple of months ago, and we're expected to launch a central team here in Central Phoenix in the next couple of months, and then a West Valley team for street medicine in February. So these teams are also expected to expand. One of the things that I talk about when I speak about expansion is that it brings great joy to know that Circle the City is innovative. And as soon as we see like there's this increase in homelessness here in county, what else can we do? The unfortunate side of it is that our expansion only means that there's an additional need, right? So as we have to expand programs, it's really to meet the needs of the increasing number. And another segment that is very near and dear to my heart is our health navigation program, and I'll talk more about that. We have health navigators embedded in different emergency departments here in the hospital systems of Maricopa County. So the major hospital systems have adopted our health navigation program. So we hire the health navigator. It's a Circle the City employee, and they're solely there to provide advocacy, patient advocacy, and ensure that patients have a safe and coordinated discharge after their visit in the emergency department. Our staffing model. So something to know when I speak about the staffing model is that each team and even region within Maricopa County has a unique need. So we'll identify what that need is and then deploy appropriately depending on that need and what we assess. So we're staffed by a medical provider. So each mobile team, street medicine team, mental health, all have a medical provider. It could be from an MD to a PA or a nurse practitioner, which, by the way, if there's any nurse practitioners on this call, happy Nurse Practitioner Week. We also have a registered nurse. So the RN is really there to support the provider, help assess wound care, provide any sort of assistance, because oftentimes in high volume sites, just one provider may get overwhelmed. So the nurse is really there to help triage, to help support the provider and patients in the community that we serve. We also have behavioral health consultants. So the BHCs are there to provide behavioral health interventions. So a little different than the mental health street medicine team. BHCs work in conjunction with the provider, same time, same appointment. So if a provider sees that a patient needs a behavioral health intervention, which these typically are 15 to 20 minutes of a behavioral health assessment, our BHCs will meet with the patient while they're on the mobile unit or at any of the sites. We do not have full-time BHCs for every single team. Some have a BHC that travels amongst them. And again, I go back to what I mentioned is depending on that need of where we are and who we're serving. Oftentimes when we partner with community partners, like in residential treatment facilities or places where they already have their in-house counselors or their in-house behavioral health team, they will not need to outsource with us, right? So it's all dependent on the need and region. We also have medical assistants here at Circle the City for outreach. We call them medical coordinators. And the only reason of the change in term is because our medical assistants really do wear so many hats. And I know we often say these about positions, but they really do. They drive the mobile unit. So there are mobile unit drivers. They do intake, right? So they do triage, vitals, paperwork, referrals. They follow up with all of the administrative tasks. They ensure that we have stock supplies, medical supplies, etc. So we changed the term a little bit to really fit the need of outreach. And last but certainly not least, we have community health workers. And again, these CHWs travel within the mobile teams to ensure that patients who need a follow-up appointment, and we feel like the provider says, you know, this person cannot miss this oncology appointment, then that CHW will take that referral and follow it from start to finish to try to ensure that the patient really does go and follow up with the oncologist, bring back the information to the provider, and really help the patient stay connected with their follow-up care, whether it's medically or through social services. Our outreach department, our mobile units, our neighborhood partnerships, as I mentioned before, are an extension of our FQHC. So Parsons Family Health Center is our first federally qualified health center that we opened here in Circle the City as far as our outpatient clinics go. We are a branch of this FQHC. So any type of care, treatment models, and processes, we try to follow the same as they would be in an outpatient clinic, just that it's in our mobile unit setting, if you will. We're able to do labs on our mobile units. We're able to do so many things. We try to not limit what we do because of the environment that we're in. We collaborate with community partners in Maricopa County, and we rotate our mobile clinic to different sites on a daily basis. Our street medicine team, so like I mentioned in the picture, you'll see them walking up a trail. And that's really the essence of what the street medicine teams do. They go to the places where our mobile teams cannot. There's an extension of our mobile medical units. Our street medicine teams provide medical care to the most vulnerable. Our street medicine approach reduces barriers to care through engagements of individuals who do not routinely seek services. Circle the City is able to expand healthcare in the homeless community and addressing health disparities. Our mental health street medicine team, again, different than the mobile unit. They travel in a small SUV to different areas, different parks, different sites throughout Maricopa County. And they're there to provide evidence-based mental health services, including but not limited to psychotropic medications to address symptoms of psychosis. The team will work to connect patients with community agencies and address other social determinants of health. And some of the services provided are mental health interventions, medication management, psychotropic treatment, case management, and connection to care and resources. Is there any other questions, Cindy, before I move on? Okay. And then we're moving on to our health navigation program. So like I mentioned earlier, we have 7 health navigators embedded in the hospital, the bigger hospital systems here in Maricopa County. Patients facing homelessness who are being discharged from a hospital may need medical respite care to complete their recovery. They need access and connection to additional medical treatment centers and to other support services. Health navigator services are effective at linking patients to post-discharge medical care, providing emotional, informational, logistical support, and problem-solving assistance. Health navigators, in conjunction with hospital clinicians and social workers, play an essential role in developing comprehensive care plans. They forge critical relationships with clinicians and providers within the healthcare systems. Health navigators support patients in their self-management to achieve medical and social stability. And like I said, these are the different hospital systems we're embedded in here in Maricopa County.
Can you talk about how did you make that happen with hospitals? I think that's just fascinating. And I know lots of people have tried different ways of partnering with their hospital, but did they come to you with that idea? Did you go to them? How did that partnership happen? And what were some of the details that you had to work out to make that possible?
Absolutely. So the first Health Navigator program launched out of St. Joseph's Hospital here in Maricopa County, Central Phoenix, and it was through a grant. So that grant was called the Community of Care Grant. We partnered with another 3 organizations through this grant. And again, we talk about that gap, right? So let's talk about COVID for a little bit. Let's not go too far back. Let's talk about COVID. So during COVID, unfortunately, many of those that we love experienced the disease, that had COVID and perhaps went to the ED because of their symptoms. And their discharge plan may have been, okay, your vitals look great now, they're okay. Isolate for 10 days, let friends and family know that you're not feeling well, reach out for support, for food, medication, whatever you need, but go and rest and isolate at home for X amount of days, right? What happened with individuals experiencing homelessness, right? Where were they being discharged to? Who was helping them connect with perhaps not family and friends, but a support system that can help them through this isolation period and after, right? And I think this is where our health navigation program really shifted. It was very highlighted during COVID times because no other program existed that was providing this coordination to care as we did for our patients experiencing homelessness, discharging from the ED for COVID symptoms. So here in Maricopa, the county actually was a huge support, both the county and the city of Phoenix. And we had what we called isolation hotels, where patients who needed to isolate were going to this hotel. But the coordination of that, a lot of it happened through our health navigation team. Social workers and clinicians were not a part of these discussions with the county, with the shelters, with infectious control, but we were, right? Because we are considered an organization that provides healthcare for individuals experiencing homelessness. So our health navigators knew exactly what the referral process was. They knew exactly who to contact for transportation. They knew exactly what the census was. At some point then, Circle the City itself as an organization became the gatekeeper of this program. So even though the hotel was not owned by Circle the City, we were the medical providers there to provide support. So this is where I think the health navigation program really was highlighted, is really seeing the need of somebody who's there to not only advocate for the patient, but somebody who's there who's very well versed in what resources are available for our patient population. So back to the grant in 2018, this is where the first health navigator program stemmed from. It was our first launch. Since then, we have grown tremendously in the last couple of years to now 7, hopefully 8 soon. And we've infiltrated most of the biggest hospital systems here in Maricopa County. Some are actually grant funded and others are paid for by the hospital itself. We have significant data throughout the years now to really show that there is a reduction in readmissions from patients who actually connect with a health navigator through their stay. So for those patients that may meet the criteria for a respite center, the health navigator will follow that referral from start to end. They'll work with our respite intake team to ensure that the patient, the documents that we need are in, transportation is set up, communication between the hospital and Circle the City. So they're that liaison. If the patient perhaps does not meet respite criteria, then we find other connections to care within the community partners that we forge these very strong relationships with. The biggest goal for our health navigators is to provide patient advocacy and safe and coordinated discharges for the patients. One of the most innovative things that I have seen come out of the program that I can't take credit for, because it's the hospitals doing this, but the hospitals have connected with our local shelter here in Arizona to lease what they call medical beds. So then patients who need additional time to heal, who do not meet a criteria for a respite or a sniff, but don't, they should not just be discharged to go find shelter. They connect with the health navigator. The health navigator then provides a referral, and the patient has a reserved bed that they're able to go to for a minimum of 5 days, where they have an additional time to heal. For those that have not been to the shelter, it gives them a little bit of a soft introduction to what the shelter is and where the meals are and where the programs are and services are. So again, these are things that some of the hospitals have already started doing. And I just feel very fortunate that they've considered our program as the gatekeepers for these medical beds that they offer. Is there anything else that I missed, Cindy? I know you and I had a conversation about the health navigation program.
No, I think that's incredible. I think you'll talk more about how the health navigators, how that connection can be made between the hospital and the mobile unit, even for follow-up care. And I think that is a fascinating component of this. I know a lot of mobile services are really interested in are really struggling with patient outreach. They show up somewhere and there's no patients there, or, and trying to figure, and yet there are these people coming out of the hospital who need care, who need to be followed up on. How can we get connected to patients that we know need a follow-up? And so I think that's a fascinating way of using community health workers, health navigators, is making that connection between hospitals and the mobile unit. If the reality is, it's going to take something special for that person to be able to get care.
Absolutely. And one of the things I always say, to our health navigators is they have the access to the most patient information, right? So we talk about it through a HIPAA perspective, patient information perspective, but also they're in the hospital. So if we know that this patient is in there and we have that ROI, we can provide the provider with information and real-time updates of what's going on. So not only do they have that relationship internally with our respite team, with our mobile outreach teams and our outpatients team, our outpatient teams, but also within the hospital system, within the information systems, they're able to provide, we have a system called HMIS here. So they have access to all of this patient information that they're able to provide real time and a more of a comprehensive picture of what's going on with this patient, right? One of the things that we encourage every health navigator to do is to make that follow-up appointment with our outpatient clinic. So if it's close in proximity to our 4-wall clinic, we actually make them an appointment. We give them an appointment card of their follow-up. But because we know that oftentimes it may be difficult for them to go to that follow-up, then we provide them with a schedule of again, depending on the region of where they're at. This is the mobile units. This is where they are, so if you're not able to follow up, don't worry about it. Come and find us at one of the mobile units. So we give them multiple options for them to come and seek that follow-up care. I will say with one of the hospital systems that we partner with in particular, again, they've done their own study and they've seen that ever since we launched our mobile unit in their region, close nearby to the hospital system, they've seen a significant decrease in readmissions for wound care, because that wound care is then being treated by our mobile unit provider and registered nurse. So just since the launch of these programs, we've done studies within ourselves. Hospitals have done studies. Again, some hospitals fund their own health navigator because they have seen the impact and reduction to readmissions, or just the impact that it also has in cost savings for the hospital systems.
That is incredible. I love the way the hospital did a study and told you, hey, just so you know, we have, I think it's also really helpful when we think about data that they did a study around a specific service that people come to the ED to receive. Sometimes when we're trying to validate mobile health services or medical respite or whatever, we do a study with the hospital or with the ED, but it's so vague that we don't capture specific information. But to know, okay, wound care is something that's really needed, and we're doing that so well, it's reducing the number of people with wounds who go to the ED. That's a very easy way to quantify that. And we have a really hard time quantifying the value of mobile health. So that's fascinating too, that they actually did that and came and told you, and that you're working together, not just with patients, but also with data. That's awesome.
No, I agree. I will say that this was one of the most successful launches of a neighborhood partnership, in my opinion, since I've been here. Because when we launched this particular mobile unit, we did it in conjunction and with the support of the hospital, because it was just in such close proximity to one of the most high volume sites that this mobile unit was going to be providing services to. So not only did we do it in conjunction with and support from the hospital, but they helped connect us with other stakeholders within the community. I mean, I went to a lot of just different town halls to talk about what we do and who we are. So then the community did not see us just pop up out of nowhere with a negative connotation. They knew who we were. They had our cell phone. They knew how to connect with us. So it was one of the a really nice launch. And I will say that before we launched, the hospital and how they knew about wound care is that they took the diagnosis that they saw the most of in our patient population before the launch. So that was something very smart that they did. So they already knew this is what we're seeing. And that's how they were able to track. Ever since they launched, we've seen that significant decrease. So I thought that was very smart of them to do. And I appreciate them for it. And every time we launch and every time I talk to them, I say, you've always been that model to follow. So ever since that first connection, we've tried to sort of follow that, the lead that they provided us with. So, and again, I wanted to end the presentation with talking about how we're always looking for innovative ways to eliminate barriers to care. We were very fortunate to be able to launch what we call the Women's Wellness Project here at Circle the City. Through a very generous donation that we received, we launched this wellness project in a series of 3. So we hope to have an additional 2 events, but we had our first series on October 27th. And the purpose of this project is to continue to find innovative ways to provide medical services for our patients by eliminating barriers and providing access to care. The Women's Wellness Project is a series of events, each focused on one aspect of women's health. Our first event focused on breast health and cervical cancer screenings in the month of Breast Cancer Awareness Month in October. That's where we took that and just ran with that idea. We had nearly 100 women attend the event from our outpatient clinics, respite centers, and outreach teams. 40 patients were transported by our own bus and vans. So we actually deployed our vans and bus to go through different community sites, different partners, different shelters that we provide services to and bring patients to the event. We had a total of 36 mammograms completed on that day and 14 cervical cancer screenings. So it was definitely an event for the books. We got to engage with a lot of patients, a lot of smiling faces. It was very interactive. We wanted to make it all about them, make them feel special while still addressing a health need. So our cervical cancer screenings were provided by our very own mobile medical unit and our own providers and staff. And then we partnered with another imaging mobile unit to provide the mammograms. We had tons of community support. So we had Beauty by Veronica, who provided haircuts and makeovers for our patient with so many patients. And there was wait times, wanted to make sure we were interactive and engaging with them throughout the event. We also partnered with another community organization that did bra fitting for them. So they were able to leave with a new bra. We provided them with free lunch. So we had a food truck come out that was providing foods and drinks and lots of health education. And the next picture is a beautiful one. So you'll get to see all of the smiling faces as they waited and they got their haircuts and mammograms and participated in the event. So not only was this a beautiful day for our patients, but it was also a great day because it really bridged all of our segments together. Respite, outpatient, and outreach all came together to make this a successful event. So I think that's one of the things that brings the most joy to me, is that we all came together to make this event successful and one to remember for our patients. So thank you. That was a whole lot in a short amount of time, but I'm open to any questions or comments that you may have for me. And I also have my information up on the screen if you want to jot it down. That way, if you don't have a question that comes up right now, but you think about it in the future, feel free to email me and I'm more than happy to address it. Thank you so much for your time.
Yeah, what additional questions for Stephanie today? One question that we talk about a lot, and I know you mentioned this when you spoke at the safety and security session that we did in October, is, and I thought it was just fascinating that you even mentioned that they have your cell phone number, is your work with the community and how you went to town halls and that's a big issue that I think a lot of mobile units face, is how to coordinate with the community. Have you had any negative feedback from the community at all, or do you feel like that's really helped to ward all that off? Or what would be some secrets as mobile units were looking at going to sites? What kinds of things would you say, not say? What did that actually look like when you were doing some of that, laying that foundation and trying to establish sites?
Absolutely. So, when I started here at Circle the City back in 2018, we were launching our third mobile medical unit. And in working with the hospital I was talking about earlier, I was just motivated.
For this assessment with Laura today at 11.
I think someone needs to mute. Let me see here.
I have my therapy appointment at 1:15.
All right, I got it.
I was just very enthused and motivated to get this launch started. And I remember one of the hospital senior leaders saying, "Hey, Stephanie, I know that you've done a lot of work in the community. I can hear it. It sounds like you're great at making relationships, but I will tell you, this is a tough community and it's going to be difficult to get into in a positive way." And I said, "Talk to me a little bit more about that." Well, this particular community launched a coalition of business owners along the street that is most impacted by individuals experiencing homelessness. And they were upset because patients were basically, they were saying, driving away our service. Our customers don't want to come in when somebody is urinating right outside my doors. So these were some of the concerns. And boy, were they not wrong, right? It was very difficult to kind of gain their trust and gain their support. But it was through a lot of education, Cindy, a lot of let us be a part of the solution. Help us help you, right? That was the message. Let us be a part of the solution. And I remember telling them, listen, there's a term that's used, but basically the individuals there are natives of that certain region. Mm-hmm. They do not want to leave that area. They are your neighbors and they've been here for decades too. So let us be a part of the connection to care. Allow us to be a part of that solution. And that's when I said, here is my cell phone number. Here are the resources that Circle the City provides. We're not just deploying a team that's just going to get up and leave and do a vaccination and go. We are there to provide medical services first because we are a medical facility. Nonetheless, we're also there to identify the social determinants of health. And our hope is to connect them to residential treatment facilities if that's what they're looking for, connect them to shelter if that's what they need, and really just gaining their trust and support in that manner, I think was huge for them. I mean, till this day, they have my email where they emailed like, hey, there's a patient who's here on the corner, doesn't look so well. Do you have somebody on the team that can come out and take a look? So we've just established that relationship and rapport with each other, right? But it took some time, and I will say it was one of the most difficult communities to launch in at. So
that's awesome. I think with all healthcare for the homeless, we see that issue. We're having a similar issue in Nashville. I'm calling from Nashville, and where we have business owners who come together with a lot of good reasons, that have had a lot of things happen that go, yeah, I can see why you're upset, but how do we reach out to them? I think it can become so, where we're just enemies, become so adversarial. So yeah, that's incredible. When you think about you I think did an excellent job of describing, the team that's on each unit. are those the same providers every time, or do providers rotate in and out from the brick and mortar to the mobile unit and street medicine? You know, how are they assigned a certain place that they're always there, or how does that work both with your mobile unit, your street medicine, and your brick and mortar?
So for the brick and mortar, they have just certain providers assigned to that brick and mortar site, to the outpatient clinic, but and the patient can see their established provider. But if that provider is out that day, they may see whatever other provider is available. For outreach, we have one dedicated team for each mobile unit, one dedicated team for each street medicine team. And that's huge, again, because we talk a lot about that rapport and trust. It may take 10 encounters with a patient before they even come up to the mobile unit, right? And everybody on the call knows this. It may take offering them what we call kindness kits. We have kindness kits here that have, soap and hand sanitizer and things that they look for that they need. Water, we carry Gatorades. And it may take a lot of like, hey, what do you need today? How can we help? No, I don't want to talk to you guys. Well, can I offer you this? Okay, I'll take it. And then the next week, hey, do you need something to drink? How are you doing today? And it just takes a couple of engagements. But I think what brings a whole lot of success in establishing rapport with patients is that it's the same familiar faces. So we do have float providers and we do have float MAs. So if a provider is out or if an MA is out, we do have an outreach float provider or an outreach MA float that will, circulate or travel throughout the different teams for coverage. But for the most part, it's the same provider, same MA, same RN for each of the teams.
Wow. So when you hire them, you actually hire them as a mobile health provider.
Yes.
Wow.
Mm-hmm.
Yeah, the floater idea is huge too, because we work with a lot of mobile units that they want to have that stable team, but if one of them is sick, they can't go out. It's like, now what do we do? So the idea of having a floater is a really cool idea too. And then you talked about your medical assistant. Is your driver always a medical assistant? Or one of the big issues we hear about is the inability to keep drivers on staff. And so do your drivers have to have a CDL or a special license? And then how do you staff your driver position?
Yeah, so the drivers here for the mobile unit, does not need to have a CDL. For our bus, because it's a 16 passenger bus, does need to have a CDL, but not for the mobile unit. And I do not hire a specific driver. It is the MA. So the MA, when I'm interviewing and talking about it, I have pictures, or also, you could come out and show you. They are hired knowing that part of their job description is to drive that mobile unit. And we don't just say, all right, here are the keys, go. No, they meet with our fleet manager. They do a driver competency test. They do different driver training. He reviews the entire mobile unit with them, gets them comfortable before we deploy them out.
Thank you so much, Stephanie. That is just incredible. That is just awesome to see the work you all are doing. And your last slide there from your Women's Event Day, I mean, you can just see in everyone's face just the impact that you're having there, even just in that one event. So that is awesome. And so much to think about there, not just with mobile services, but with healthcare for the homeless across the board. But so much to think about there in making partners in the community and how you're using health navigators, especially. That gives me a lot to think about. So I really appreciate it. It's always good to hear about Circle the City and what you guys are doing. We encourage everyone, if you have any more questions or any more thoughts, feel free to email them to me. We do provide technical assistance around mobile health, so we're happy to answer questions, to connect you to resources like Circle the City, if that's something that would be helpful. And we will have all the recordings from all the sessions from September and October, and the sessions we've done here, all available in one place. And I will be emailing that out to everyone who has registered, so you can watch for that too. Yeah, thank you so much for joining us for all of our mobile health offerings over the last couple of months. And thank you so much to the Leon Lowenstein Foundation, especially. And we will close out. Good afternoon to everyone, and have a good Thanksgiving and good rest of the week.
Thank you so much, Cindy. Thanks, everyone. Bye-bye.